Hi everyone. Today I'm going to lecture about the functional anatomy of the heart. I am Arik Paolo Delacruz. I am an assistant professor 2 at the WVSU-College of Medicine. Here are my references for this lecture. Snell Clinical Anatomy, 9th edition. Guyton and Hall Textbook of Medical Physiology, 13th edition. Bates Guide to Physical Examination and History Taking, 12th edition. And I also got various internet resources. All the images in these lectures are not mine. These are used only for educational purposes only. And I really give credits to the owners. I will also give credits to the video from YouTube, Meditay, Anatomy of the Heart and Internal Structures. If you have time, try to view it. It's really good. And also Cardiac Cycle by LuxsonTube. And I also got the 3D heart animation from SketchFab 2018. I also use cygotbody.com as my anatomy atlas. It is online, it is free, so I suggest you sign up. It's really good and it's free. You can sign up. So here is the outline of my lecture. First, I will talk about external structures of the heart, the internal structures of the heart, the walls of the heart, including the pericardium, the conducting system of the heart, the coronary circulation and nerve supply of the heart, as well as surface landmarks. So the heart is situated in the chest, and it is just situated underneath the sternum. And if we remove the sternum and the associated costal cartilages, we'll see the heart. The heart is situated between two lungs, and it is in the middle mediastinum. And this is the heart that we remove from everything else. So the heart looks like this one when viewed up front. It is actually skewed to the left. So what you're actually seeing is the right side of the heart. You can see part of the left side here, but mostly, since it is skewed to the left, more of the right structures are seen up front. Here is the anatomy atlas by cygotbody.com, and here, if we take a look at the model in front, you'll see the heart is skewed a little bit to the left, rotated to the left. And what you see when you are facing the person, you will see the right side of the heart. When you let the person turn to the right, the left will be visible, and it is more situated at the side as well as in the back, the left structures. So this is a really good anatomy tool, since you can see everything from the skin down to the heart. Let's talk about circulation. The blood vessels of the body are functionally divided into two distinctive circuits, the pulmonary circuit and the systemic circuit. The pump for the pulmonary circuit, which circulates blood through the lungs, is the right ventricle. The left ventricle, on the other hand, is the pump for the systemic circuit, which provides the blood supply to the tissue of the cells. Pulmonary circulation transports oxygen-poor blood from the right ventricle to the lungs, wherein the blood gets oxygen. Then it returns to the heart via the left atrium. The systemic circulation provides the functional blood supply to all body tissue. It carries oxygen and nutrients to the cells and pick up carbon dioxide and waste product. Systemic circulation carries oxygenated blood from the left ventricle to the arteries to the capillaries in the body. Then the capillaries in the body will pick up again the oxygenated blood and carries it back to the right atrium, and thus completing the cycle. Take note that all vessels that comes from the heart are called arteries, and those vessels that come to the heart are veins. Here we have the pulmonary artery. It is a vessel that comes off from the heart and goes to the lungs, but this is the only artery which carries deoxygenated blood. And here we will see the pulmonary vein. It's the only vein that carries oxygenated blood to the heart. So this is the pulmonary circulation, and this is the systemic circulation. There are important structures to note. We have the tricuspid valve. It is the valve that separates the right atrium from the right ventricle. And also the pulmonary valve, which is the valve between the right ventricle and the pulmonary artery. We also have the bicuspid valve, which is between the left atrium and the left ventricle. It is sometimes called the mitral valve after the mitre of the Pope, because the mitre of the Pope has two cusps, the same with the bicuspid valve. Bicuspid valve, compare that to tricuspid, which has three cusps. And we have the aortic valve, which is situated between the left ventricle and the aorta. Let's go now to the external structure of the heart. So this is a cadaveric heart. This is the heart when you see it in front. Again, what you see in the front is mostly the right side of the heart. And this image is the heart seen from the back. So at the back, you will see more of the left side of the heart. Here we see the right atrium and the right ventricle. Here we see the left atrium and the left ventricle. We also have the terms such as apex, which is the tapered end of the heart situated inferiorly. And we also have the base, which is superiorly and more at the back. Let's talk about surfaces of the heart. So if this is the heart and we remove the lungs, the costal cartilages, the breastbone or the sternum, we'll see the heart. The surface which is in contact with the lungs is what we call the pulmonary surface. And the surface that is in contact with the diaphragm below is the diaphragmatic surface. And the surface that is staring in front of you is the sternal surface. So again, this is the heart as seen in the front. We'll see here prominent landmarks. First is this one. This is a groove. This is what we call the atrioventricular groove or the AV groove. The AV groove separates the atrium from the ventricles. That's why it is called an atrioventricular groove. When you follow the groove to the back, it also separates the left atrium from the left ventricle. So this is again the heart. So this is the AV groove, and if you follow that at the back, it grooves down and up, and this groove will separate the right atrium from the right ventricle, as well as the left atrium and the left ventricle. So that is the groove we see there. So the AV groove will tell us where the atrias are, the left atrium and the right atrium, from the left ventricle and the right ventricle. We also have this line in front, and this is what we call the anterior interventricular groove. From the term itself, it is interventricular. It means that it delineates one ventricle from the other. In this case, the right ventricle from the left ventricle. So this groove will tell us this is the right ventricle and this is the left ventricle. When you follow it inferiorly and it curves again to the back and up, this will be the posterior interventricular groove, and we'll have an idea that this is the right ventricle and this is the left ventricle. So in the zygote, this is the interventricular groove, and we follow that. There it is, and this should be the left and this should be the right. If you have to cut the heart in this plane and take a look at the structures inside after removing this part, we will have this inside peak of the heart. These will be the chambers of the heart. This is the right atrium and this is the left atrium. This is the right ventricle and this is the left ventricle. The right atrium is separated from the left atrium by the atrial septum, and the right ventricle is separated from the left ventricle by the ventricular septum. The upper part of the ventricular septum is a little bit thinner than the lower part. It is more fibrous than muscular. So it is what we call the membranous part of the ventricular septum, and the thicker muscular part of the septum is what we call the muscular part. The right atrium. So in this image, because we already know the atrioventricular groove, this should be the right atrium. In this picture, this is the right atrium. This should be the anterior wall of the right atrium. The anterior part of the right atrium has a very characteristic feature. It has parallel muscular fibers, which we call the pectinate muscles. So this is a heart seen from the right, and it has a cut over the right atrium. We'll see here the superior vena cava, the one that delivers the oxygenated blood from superior down to the right atrium. And we have the inferior vena cava, which delivers the oxygenated blood from the body to the heart. We'll also see a ridge over here, and below this ridge is the fossa ovalis. Fossa ovalis is a depression in the right atrium at the level of the interatrial septum, and it is a remnant of the foramen ovale during fetal development. Just above the fossa ovalis is what we call the annulus ovalis. It is thickening just above the ridge. Here again, we see the pectinate muscles, which is characteristic of the right atrium, and it is seen here as a rough surface, and we also see a smooth surface. This is what we call the sinus venarum, and the one that delineates the rough and the smooth surfaces is the crista terminalis. You can also see here the opening of the coronary sinus, which is the venous drainage of the heart. The venous drainage of the heart drain into the right atrium, as we will see later. If we have to move this heart a little bit more forward and see through here, we will have this image. Pectinate muscles, fossa ovalis, annulus ovalis. We can see through the atrioventricular orifice, and in the orifice you can see already the tricuspid valves. Let's go back to the annulus ovalis and the fossa ovalis. This is found in the atrial septum in the right atrium, and it represents fetal remnants when the heart is still developing. So this is a developing heart. Fossa ovalis in the fetus is known as the foramen ovale, and fossa ovalis is represented by the persistent septum primum. This is the septum primum, and annulus ovalis is the upper margin of the fossa, this one, and it is the lower edge of the septum secundum in the fetus. This is the septum secundum. So the depression is representative of this depression over here. We'll go now to the right ventricle. So if we cut the heart in the front, we will see the insides of the right ventricle. So this is the tricuspid valve at the base, and we also have the pulmonary valve on top. The right ventricle has a rough, inside the right ventricle, we'll see the rough surface of the muscles. We call it the trabeculae carneae. And here we can also see the chordae tendineae. This is the tendon which holds the tricuspid valves, and the intermediary muscle between the chordae tendineae and the muscular part of the ventricle is what we call the papillary muscles. So this is a good view of chordae tendineae attached to the tricuspid valve, and the muscle intermediary between the ventricle and the chordae tendineae is what we call the papillary muscle. Here we'll also see a band of tissue which is more horizontal than the rest. This is what we call the moderator band. The moderator band contains some nerve fibers from the right bundle branch, as you will see later. You can also see here the cusp of the tricuspid. So the tricuspid has 3 cusps. So we have the septal cusp, it is nearest the interventricular septum. We have the anterior cusp, which is in front, and we have the posterior cusp, which is at the posterior end. And you will also see a ring-like structures around the cusp. This is what we call the annulus fibrosis, and this is a fibrous ligament which holds all the cusp. Here we will examine the pulmonary valve. The pulmonary valve has 3 semilunar valves, and it also has a annulus fibrosis around it to support the valves. So this is a view from the top, and this is the pulmonary valve. So the pulmonary valve has cusp. It looks like a reverse umbrella, 3 reverse umbrella, wherein there is a concavity, and it has 3 of these. See, this is looks like a reverse umbrella, and the space in the semilunar valve is called the pulmonary sinus. Okay, the space is the pulmonary sinus, and the flaps of tissue are called the semilunar valves. Let's go now to the left atrium. After the blood goes into the lungs, the blood then goes back into the heart via the left atrium. As expected, the left atrium is more into the left side and in the back. So this is a view of the heart from the left and from the back. The left atrium receives the blood via the pulmonary veins. Again, these are the only veins which carries oxygenated blood. This is the posterior wall of the left atrium. This is the left ventricle, and this is the atrioventricular groove. And if we cut the left atrium up, you will see the medial wall, and this is the orifice, the opening, and it is called the left atrioventricular orifice. The left atrioventricular orifice has the bicuspid valve or the mitral valve. Now let's go now to the left ventricle. So if you cut the left ventricle and see what's inside, this is the entrance to the left ventricle from the left atrium, and we'll see clearly the bicuspid valves, supported again by the annulus fibrosus, and it also has the chordae tendineae, just like the right ventricle, and the papillary muscles. If we twist this view and to look up here, we can see the aortic valve. So we also have the semilunar valves of the aortic valve. It looks like a reverse umbrella. And what differs it from the pulmonary sinus is that it has openings on the right semilunar valve and the left semilunar valve. And this is the entrance to the coronary arteries. This is the right coronary artery, and not seen here is the left coronary artery, as we will see later. This is how the heart will provide blood for itself. After pumping the blood to the aorta, some of the blood will go into the aortic sinus, and it will go inside the right coronary artery and the left coronary artery. If you have to cut this again, this is the left atrium. The left atrium is more horizontal, and This is already the aorta. The blood flows from here, then up there. And this is the aortic valve. So here is a good way to see the insides of the heart. So this is a cut heart. This is the right atrium, and this is the right ventricle. This is the tricuspid valve, chordae tendineae, papillary muscles, moderator band, trabeculae carneae, interventricular septum. So blood goes here, then goes up there. That's the pulmonary valve. Goes out via the pulmonary artery. Then it goes into the lungs. From the lungs, blood is drawn back into the heart through the left atrium. So this is the left atrium, right atrium, left atrium, and this is the atrioventricular groove. See? It's there. So we have 4 pulmonary veins, the only veins that carry oxygenated blood. And this is the left atrium. From the left atrium, it will fill the left ventricle with blood via the bicuspid valve. From here, the left ventricle, which is thicker than the left ventricle, it will propel blood into the body via the aortic valve. Okay, that's the aortic valve. Okay, so that's the aortic valve. The aortic valve has openings in its semilunar valves. So this is one of the opening. So let's talk about the pericardium. So this is again an image of the heart, but the heart actually has a covering on it, and if you can see here, and it is covered by a layer of tissue. The outermost covering is what we call the fibrous pericardium. See, if we peel this off, and just inside the fibrous pericardium, just inside a bit, is what we call the parietal pericardium. It is the pericardium that is facing the heart. The fibrous pericardium is facing the other structures in the chest. And once you peel it, there is another pericardium, which we call the visceral pericardium or the epicardium, which is more intimate with the muscles of the heart. So pericardium is a fibrous sac that encloses the heart and the roots of the great vessels. So it is pictured like this one. And another picture, this is the pericardium. The functions of the pericardium are the following. It restricts excessive movement of the heart. It acts as a lubricated container wherein the heart can contract. So this is a good diagram to show the different parts of the pericardium. So we have the fibrous pericardium, the thickest one. And it is attached to the central tendon of the diaphragm below. It also coats the great vessels passing through it. So not only the heart, but also the great vessels. And we have the serous pericardium. This is the pericardium more intimate to the heart, and it has 3 layers. The first is the parietal layer. It is the layer which is very intimate to the fibrous pericardium. And we have the pericardial cavity, which contains around 50 ml of pericardial fluid. And we have the visceral layer, which is more intimate with the heart and is also known as the epicardium. The walls of the heart, if we take a chunk of the heart here, of course, the outermost part is the fibrous pericardium, followed by the parietal layer of the serous pericardium, then the pericardial cavity, and the epicardium or the visceral layer of the serous pericardium. Okay, this is pericardium, and this is already the wall of the heart. After the epicardium, we have the myocardium. From the word itself, myo, it means that it is composed mostly of muscles. And we have the endocardium, which is the inner layer, which is found inside the heart. And this is another view of the walls of the heart. This is the fibrous pericardium. There's a layer after it. It is what we call the parietal pericardium, the pericardial cavity, and the epicardium, the visceral pericardium. This is the myocardium, which is composed mostly of cardiac muscles. And this is the endocardium, which is an endothelial layer which lines the inside of the heart. Endocardium lines the inside of the heart, as well as it lines the valves of the heart. The myocardium, this one, is composed of muscles, connective tissues. The myocardium forms the bulk of the cardiac muscles, as well as a fibrous annulus, which is what we call the skeleton of the heart. So earlier, I always stress that there is a fibrous ring all over the valves. We call it the annulus fibrosus. Seen here, 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 and here. These are actually fibrous rings which are found in the atrioventricular, pulmonary, and aortic surfaces, seen in blue in this figure. It supports the valves. And if you have to remove everything else, remove the muscles, the valves, you will have this one. These are fibrous rings. It is sturdy enough to support the valves. And the functions of it are the following. It separates the atria from the ventricles. It supports the bases of the valve cusp. It also serves as a basis of electrical discontinuity between atria and the ventricles. So it can be likened to the six-pack rings we see when we buy beverages. Looks like that one. It supports everything else. Very thin, but it supports well. Let's talk about the myocardium of the atria. So this is the atria. So the myocardium of the atria has two layers, which is the outer circular and the inner longitudinal. If you have to remove the outer layers of the heart, we will see the outer layer is circular one, and the inner layer we'll see as longitudinal, as we see here in the pectinate muscles. So outer, it is circular, and inner, it is longitudinal. Myocardium of the ventricles has three arrangement of muscles. We have the outer longitudinal, the middle circular, and the inner longitudinal. The inner longitudinal is also the one responsible for the appearance of the trabecular carne as seen earlier, as well as the papillary muscles. One distinct feature of the myocardium of the ventricles is that the longitudinal muscles connect from outer to inner. The longitudinal muscles from the outer longitudinal and the inner longitudinal, they connect with each other from outer to inner. They do not connect to the middle circular, but it connects from outer to inner and outer to inner. It forms a vortex, so outer to inner, outer to inner. And this is what it looks like. The middle circular does not form a vortex, but it surrounds each ventricles and is mostly concerned with the contractility of the heart. As you can see here, the right ventricle has a thinner middle circular layer than the left. It is because that the right ventricle does not need to have much force to pump the blood into the lungs, compared to the left ventricle, which needs a lot of force to move blood from it to the rest of the body, so it entails a thicker middle circular layer. Let's talk about the conducting system of the heart. So generally, the atria will contract first before the ventricles. So the impulse should come from the atria, then to the ventricles. It starts with the sinoatrial node, then impulses goes into the AV node, found here, down to the bundle of His, and from the bundle of His, it separates into the right and left branches or bundle branches, and end up ultimately as Purkinje fibers. The normal firing rate of the heart is 70 to 90 at the sinoatrial node, and 40 to 60 at the AV node. The rate of the impulses is very much influenced by the sympathetic system, which usually increase the rhythm and the rate of conduction, and the parasympathetic system, which decrease the rhythm and the rate of conduction. The sinoatrial node here is found in the upper part of the sulcus terminalis in the right atrium, just right of the superior vena cava. This is what we call the pacemaker of the heart. What the sinoatrial node says, the rest of the heart will follow. That's why it is called pacemaker. So the sinoatrial node is found in the right atrium, and it will transmit signal to the left atrium via the Bachmann's bundle. It will also transmit signals inferiorly to the AV node via the following tracts: the anterior tract, the middle tract, and the posterior tract. The AV node is found in the lower part of the atrial septum, just above the septal cusp of the tricuspid valve. This is the septal cusp of the tricuspid. It's found there. The AV node, upon receiving the signals from the sinoatrial node, delays the impulse of approximately 0.1 seconds. This will allow the ventricles to contract a few milliseconds after the atrial contractions. From the AV node, the impulses will travel into the bundle of His, down to the right bundle branch and the left bundle branch, and end up ultimately as Purkinje fibers. The bundle of His is found at the lower part of the atrial septum, just above the septal cusp of the tricuspid valve. The right bundle branch has a distinct structure. We call it the moderator band, which we have discussed earlier. So this is the moderator band, and it contains the right bundle branch. The left bundle branch divides into anterior and posterior branches. So earlier I said that the heart is heavily influenced by the autonomic nervous system, the sympathetic and the parasympathetic. Sympathetic means fight, means it has to do more work, and parasympathetic is rest and it do less work. So the sympathetic innervation to the heart comes from the cervical sympathetic trunk, and it has catecholamines as the main mediators, and it has endings at the SA node, AV node, ventricular myocardium, and the following receptors will cause increased pacemaker activity of the SA node, increased heart rate, increased stroke volume, increased contractility, and dilation of the coronary arteries. So dilation so that the heart will receive more blood from itself. Parasympathetic, on the other hand, mediated through acetylcholine, and it involves the sinoatrial node, AV node, and the atrial myocardium. We do not have parasympathetic innervations to the ventricles, just like the sympathetic ones. And the basal vagal tone dominates the SA and AV nodes at rest. So the parasympathetic dominates at rest. Simply put, the sympathetic nervous system will increase the efficiency and the contractility of the heart, and the parasympathetic will decrease the contractility of the heart. So this image will show the innervations of the heart, the sympathetic via the cervical trunk. We can see here that it innervates as far as the ventricles, and the purple lines are those from the parasympathetic nervous system via the vagus nerve, and it only supplies the SN node and the AV node and some of the atrium, but not the ventricles. Let's go now to the arterial supply of the heart. So the heart is essentially nourished by itself through the right coronary artery and the left coronary artery. So this is the left coronary artery, and this is the right coronary artery. It stems from the aorta itself. And if you can still remember, we have the semilunar cusp in the aortic valve. The semilunar cusp is like a reverse umbrella, but compared to the pulmonary valve, it has holes in it. And these are openings to the right coronary artery and the left coronary artery. So when the heart pumps, some blood be retained in the aortic sinus and it will go through the coronary arteries. That's how the heart nourishes itself. The right coronary artery, this one. So top view, these are the semilunar valves, and you'll see an opening, and this is the right coronary artery. It goes to the right, then goes posteriorly. So the branches are the sinoatrial nodal branch, this one. Of course, it is the artery of the SA node. You also have a branch of the right conus, and as it goes down, it gives off a branch. We call it the marginal branch. Here. Marginal means margins of the heart, so it is near the edge of the heart. So this is the marginal branch, and it is the largest branch of the right coronary artery. It can be really long and it can even reach the apex. The right coronary artery can also have a ventricular branch, and when it goes posteriorly, it will end up at the back and branch off a posterior interventricular branch. And this determines the dominance of the heart, as you will see later. The left coronary artery is from the left aortic sinus, again, from the cusp, goes there, and found here. Branches are the following. We have the anterior interventricular branch. It is found in the interventricular groove. Sometimes they call it the left anterior descending or the LAD. The LAD will have a branch also. This is the left diagonal artery. The left coronary artery will also have a branch which we call the circumflex branch. This one. The circumflex artery will also have a branch, a marginal artery, this one, near the margin, but it is more located posteriorly, and it supplies the left ventricle to the apex. The left coronary artery will also continue as a posterior ventricular artery here, and some atrial branches. So there are variations and anastomosis in the coronary circulation. We have terms such as right dominance, wherein the posterior interventricular branch is from the right coronary artery. This one is from the right. But there are what we call the left dominance, wherein the posterior interventricular branch is from the left coronary artery. All coronary arteries are functional end arteries, meaning they don't have much anastomosis. So that's why when you have a block in one of the arteries, that area that is supplied by that artery is often ischemic. So take care of your coronary artery, because once it is blocked, you will have a heart attack. Let's talk about the arterial supply of the conducting system. So again, we'll put an image here of the conducting system. So the SA node is supplied by the right or left coronary artery. The AV node is supplied by the right coronary artery. The right bundle branch is supplied by the left coronary artery, and the left bundle branch is supplied by the left coronary artery or the right coronary artery. Venous drainage of the heart. So the heart also has its own venous drainage, and ultimately all the deoxygenated blood from the heart itself drains into the coronary sinus over here. It is found the posterior end of the heart, just below the left atrium. As seen earlier at the slide, there is an opening in the right atrium just left of the inferior vena cava. So this is the inferior vena cava, and this is where the coronary sinus will drain into the heart. The tributaries of the coronary sinus are the following. We have the great cardiac vein. This is the vein in front in the interventricular groove. It goes up and at the back and joins the coronary sinus. We also have the middle cardiac vein. It is found mostly at the back. And we have the small cardiac vein, which is more on the right side. They all join first the coronary sinus before draining into the right atrium. We also have the anterior cardiac veins here, which drains the right ventricle, and it drains directly into the right atrium. It doesn't join the coronary sinus before draining into the right atrium, but instead it drains directly into the right atrium. And we also have thespian veins, which are the smallest cardiac veins, and these drain directly to the wall of all four chambers. So these are thespian veins, and it drains directly to the wall. So instead of draining it outside, it drains directly into the lumen of the heart. So here we have an animated heart from SketchFab. So this is the front face of the heart. So this is the atrioventricular groove. So this should be the right atrium and the right ventricle. And this is the interventricular groove. So this should be the right ventricle, and this is the left ventricle. This is again the continuation of the atrioventricular groove. So this should be the left atrium and left ventricle. So this is the aorta, and the aorta will give rise to the coronary arteries. This should be the right coronary artery, and this is the left coronary artery. So we have the right coronary artery. It will have branches to the right atrium as well as the right ventricle. But as you can see here, this is in the margin. We call it the marginal branch of the right coronary artery, and this is very large and sometimes very long. It reaches to the apex. The right coronary artery will continue to the back in the atrioventricular groove, and in this point it can form the posterior interventricular branch. This one, from the term itself, inter, between the two ventricles. So this posterior interventricular branch can be from the right coronary artery or the left, and that is what determines the dominance of the heart. So it can be from the right, it can be from the left. Now let's go now to the left coronary artery. So this is the left coronary artery. So as you can see, the left coronary artery has a very big branch in the front. This is what we call the anterior interventricular branch, because it is found in the interventricular groove. Sometimes we call it the left anterior descending. So it's a very big branch. And this one is the circumflex branch of the left coronary artery. The left circumflex branch will give rise to a marginal branch. This is what we call the left marginal branch, and it will continue to the back. And it can also be the main artery for the posterior interventricular artery. Along the way, it can give off to several atrial and ventricular branches, and we can see it here. So let's talk about the venous drainage of the heart. It is seen here in the blue vessels. So in the front, we'll see here the great cardiac vein. The great cardiac vein is the one that is found in the interventricular groove, and it continues to the back as the coronary sinus. The coronary sinus will drain into the right atrium. This is the right atrium. Okay. So that's the great cardiac vein. We will also see this one. This is from the middle, of course. We call it the middle cardiac vein. This is the coronary sinus. This one We call it the posterior cardiac vein. So middle, posterior, great cardiac vein. On the right side, this is what we call the small cardiac vein. This is a small cardiac vein, and it still joins the coronary sinus. So actions of the heart. So we have already discussed the actions of the heart. It involves the systemic circulation and the pulmonary circulation, as seen by the arrows. The gray arrows are the pulmonary circulation, and the red arrows are the systemic circulation. So the rate of the heart is 70 to 90 normally in adults, and a little more faster in babies, which can reach up to 150 beats per minute, and it is still normal. But the actions of the heart can be more appreciated by studying the cardiac cycle. And to explain the cardiac cycle, it is better to take a look at the following videos.
This animation illustrates a single cardiac cycle, starting with the right side of the heart. In reality, of course, the two sides of the heart work together at the same time, but it is easier to understand if we look at them separately, because each side of the heart has a different function. The cardiac cycle begins as deoxygenated blood flows from the body into the right atrium via the superior vena cava and inferior vena cava. In the next phase of the cycle, the right atrium contracts, pumping blood into the right ventricle through the tricuspid valve. Once the right ventricle fills with blood, the tricuspid valve closes to prevent blood flowing back into the atrium. The right ventricle contracts, forcing the pulmonary valve to open as blood is pumped into the pulmonary artery. Blood then travels to the lungs and the pulmonary valve closes. At the same time, the right atrium relaxes, ready to accept the next intake of blood. In the lungs, the blood picks up oxygen and releases carbon dioxide. Oxygenated blood flows from the lungs into the left atrium via the pulmonary veins. The left atrium contracts to pump blood into the left ventricle through the mitral valve. Once the left ventricle has filled with blood, the mitral valve closes. Next, the left ventricle contracts, forcing the aortic valve to open, allowing blood to be pumped into the aorta and from there around the body. The aortic valve closes to prevent blood flowing back into the left ventricle, and the left ventricle relaxes, ready to accept the next intake of blood. Cardiac cycle is now complete. This animation explains how a cardiac cycle is produced by electrical impulses in the heart. The cardiac cycle starts when an electrical impulse or action potential is generated by the sinoatrial node. The electrical impulse travels along specialized conducting fibers in the walls of the atria, stimulating the atria to contract and pump blood into the ventricles. In the normal heart, impulse travels very rapidly. As a result, all the muscle cells in the atria contract together, producing a coordinated pumping action. The impulse also travels across the right atrium to the atrioventricular node, where it is delayed slightly to allow the ventricles to relax and fill with blood before they contract. The impulse travels along the bundle of His, where the conducting pathways divide in two, forming the left and right bundle branches, which lie in the interventricular septum. From the bundle branches, the impulse spreads into the inner walls of the ventricles via specialized conducting fibers, called Purkinje fibers. Finally, the impulse travels up the outer walls of the ventricles towards the atria. The rapid and controlled spread of the electrical impulse through the ventricles stimulates the muscle cells in the ventricles to contract together and pump blood efficiently to the lungs and body. The Electrocardiogram, or ECG, is a recording of the heart's electrical activity via leads placed at standardized points on the subject's body. This animation shows how the different ECG waves are produced during a cardiac cycle. The P wave is produced as the electrical impulse travels through the atria, causing them to contract. The P wave corresponds to atrial depolarization. The impulse then travels through the atrioventricular node, producing a flat section on the ECG known as the PR segment. The PR segment is flat because no current is flowing through the cardiac muscle cells. As the impulse travels from the AV node to the bundle of His and along the upper part of the septum, the Q wave is produced. The passage of the electrical signal through the ventricles produces a large spike called the QRS complex. The QRS complex is much larger than the P wave because the ventricles are much larger than the atria and so produce more electrical activity. Most of the QRS complex represents depolarization of the left ventricle, which has much greater mass than the right. The impulse remains unchanged for a moment as the ventricles remain depolarized. This gives rise to another flat section called the ST segment. As the impulse fades away and the ventricles repolarize, the T wave is formed. Note, this animation shows the ECG recorded from a lead placed at position V6, one of the standard electrode positions to the left of the heart. Leads at other positions detect the electrical activity of the heart from a different point of view, and therefore produce differently shaped ECGs.
So let's go now to the surface anatomy of the heart. This is from the Bates Guide to Physical Examination. So again, the heart is a little bit skewed to the left, and so the sternal surface is composed mainly of the right ventricle. Heart itself is situated below the line of the second left and right intercostal space, so between the two costal cartilages. So intercostal space, draw a line over there. The heart is found below that and just above the sternal xiphoid junction. And if we draw a line in the fifth intercostal space as well as the mid-clavicular line, middle of the clavicle, this is where we will appreciate the cardiac apex or the point of maximal impulse. This is very useful when we are going to auscultate the heart. And the mid-clavicular line also is the surface landmark for the edge of the left ventricle. In auscultation of the heart, we are actually listening to the different sounds produced by the different valves. So for the aortic valve, we could appreciate it if we put our stethoscope in the second right intercostal space over here. The pulmonic valve, we will appreciate it if we put our stethoscope in the second and third left intercostal space. The tricuspid is more appreciated if we put our stethoscopes in the left lower sternal border, and the mitral valve is more appreciated in the apex, which is, as seen in the previous slide, is found in the fifth intercostal space mid-clavicular line. Development of the heart. So the heart starts to beat at third week, but blood flow is appreciated on the fourth week. The heart is actually a tube that is twisted upon itself, and thus we will see the different chambers develop from a single tube. Another video will explain this development a little better, so try to take a look.
Early in the development, the primitive heart develops as two tubes that merge into one tube. The single tube begins to swell and develop into various anatomic features of the heart. The heart begins to beat by week 3. In normal cardiac development, the cardiac tube will twist and turn on itself in a rightward direction. This is called dextral looping. This results in the right ventricle developing on the right side of the heart and the left ventricle developing on the left side of the heart. Abnormal looping in a leftward direction is called levo-looping. This results in the right ventricle developing on the left side of the heart and the left ventricle developing on the right side of the heart. Entering into the 4th week of fetal life, the atrial septum and ventricular septum begins to form. The atrial septum grows in layers and includes the tissues of septum primum, septum secundum, and endocardial cushion tissue. The endocardial cushion tissue is located in the middle of the heart. From this tissue arises the tricuspid valve, mitral valve, part of the atrial septum and part of the ventricular septum. Septum primum grows downward between the right and left atrium and eventually fuses with the endocardial tissues. The septum secundum grows parallel to the septum primum. Both septum primum and septum secundum develop with holes in them to create a passageway for blood to flow from right atrium to left atrium through the foraminal valley. As long as the pressures on the right atrium are higher than pressures in the left atrium, the passage will stay open to allow the blood to flow from right to left. The aorta and pulmonary artery develop from a single tubular structure, the truncus arteriosus. Two areas of thickened tissue project into the lumen of this tube on the right and left side. As they continue to grow in size, these ridges meet and fuse to form a septum which takes a spiral course toward the end of this tube. This septum divides the truncus into two vessels, the aorta and the pulmonary artery. The conal tissue involved in the septation of the truncus arteriosus also directs placement of the aorta and pulmonary artery over their related ventricles. By the 5th week of fetal life, the atria completely separate into the right atrium and left atrium. Also at this time, the ventricular septum continue to grow in size. The muscular portion of the ventricular septum develops from the apex of the common ventricle. The membranous septum develops from the endocardial cushion tissues. Conal tissue contributes to the complete closure of the septum between the aortic and pulmonary valves. By the 6th and 7th week of fetal life, the ventricular septum completely separate into the right ventricle and left ventricle.
So that's about the development of the heart. And the lecture is finished. So if you have any questions, just contact me at the following contact information, or you can view the video again via my website. And thank you.